everyone welcome to Rehabilitation Sciences YouTube channel, and we are here with another very interesting topic today: assessment and physiotherapy regime for postnatal mothers and evidence-based practice perspective. And we have with us Dr. Deepthi. She is master's in urology and obstetric physiotherapy. She is lecturer at AIMS University, Malaysia. Ma'am, we want your consent for making your lecture live on YouTube, ma'am.
Okay, sir.
Thank you, ma'am. And we have moderator today, Dr. Sagun Agwal. He will introduce our faculty formally today and we'll start the session. Dr. Sagun, please.
Thank you, sir. Good evening, everybody. Welcome to the Rehabilitation Science Club. Today, we are having privilege to have Dr. Deepthi with us. She is doctor in physiotherapy in urology and obstetrics. I would say it's a new branch is there. Usually, we would find it out a lot of PhD in orthopedics, neurology, but few are there in the field of the urology and the obstetrics. Thank you, Dr. Deepthi, for choosing of this branch. She has did her PhD doctorate from the Savita University. She is having total professional experience of 7 years and 3 years of academic experience. Nowadays, Dr. Deepthi is working as a lecturer in AIMST University, Malaysia. Dr. Deepthi has numerous peer-reviewed papers, publication in national and international journals. She has taken up a lot of CMEs, workshops in their career, and we wish she would be going ahead in Malaysia and our country name would be come forward. Thank you, Dr. Deepthi, for coming on our channel. You can now start the lecture.
Thank you, Doctor, for giving the platform. So here I start my presentation. The topic is assessment and physiotherapy regimen for postnatal mothers. It's an evidence-based perspective. So let me start with what is postnatal period. So the postnatal period, so it is interchangeably called as postpartum, puerperium, puerperal period, immediate postpartum period, all that. So the first 6 weeks to 6 months following the childbirth is called as postpartum period. So the acute, so it is divided into acute, subacute, and the late stage. So the acute stage lasts for 24 hours. So usually in the acute stage, we use the word puerperal. Okay. Then followed by subacute till 2 to 4 weeks. Then followed by the late stage till the 6 months. So this is how the postnatal period has been divided by WHO. And you can see the symbol like PX. So this means postnatal period, the X means you can put the number. Suppose the postnatal period 1, postnatal period 2, postnatal period 3, like that. So the day of the postnatal period. So let me just give a glimpse about the changes during the immediate postnatal period. The first one is the involution of your reproductive organs. It is your uterus, your vagina. Okay, so it happens till 6 weeks. Then loggia, that is the fatty endometrial cells. It comes out. So it's just like a menstrual thing only, but the component differs because during the normal menstrual cycle, the components of the menstrual blood will differ. So here the loggia, this component will differ. So that's why it's termed as loggia. Then your abdominal wall. As we all know, you have a flabby abdomen because till 9 to 10 months the abdomen will be big, and one fine day the baby comes out, the uterus will go for involution and your abdomen muscles and all will just go flabby. Then your breast. So some women will start secreting the colostrum right from the 3rd trimester of the pregnancy. Excuse me. So this mother, after delivery, the mother will start secreting the milk. Then endocrine, you have prolactin, oxytocin, and male hormones. Then bowel and bladder. So this bowel and bladder will not return to the pre-pregnant state. So for some women, it remains atonic. The problem with the atonic bladder is there will be a retention of the urine inside the bladder. So that needs to be carefully checked because after delivery, if the woman has undergone any trauma, obstetric trauma or something, the woman will have pain over the perineum and they will hesitate to void urine. So in that case, will lead to the urine retention. So retention of or above 150 ml of urine inside the bladder, then we address it as a urine retention. Then your integumentary system. So that is nothing but during pregnancy, your linea alba, that is the line which connects both your abdominal muscles. So you will have those changes. You will have a stretch marks, you will have a linea nigra, chilasma, all that around the neck, all that. So those will remain in the acute postnatal period. So it will take some time to settle down. So why I am addressing all these things is these things should be addressed during the antenatal classes. So what the mother can expect soon after the delivery. Okay, so you have here the education is more important than the rehabilitation. So you have to make the mother understand what will happen after delivery, what the one can expect. So all these things you should inform to the mother. Then coming to the abdominal muscles. As we all know, we have 4 muscles. We have transverse abdominis, that is the deepest one. Then you have that is like immediately above your spine. So behind you have a multifidus. Then you have rectus abdominis, then internal and external oblique muscles. Whereas this only the rectus abdominis is aligned, that is your six-pack muscle, that is aligned vertically. So once the baby started to grow, what happens? This rectus abdominis muscle will give a way for the growing uterus, because at your uterus reaches to the till diaphragm. So this muscle just gives a way. These muscles are connected through the linea alba, that is nothing but the fibrous sheet. So these muscles just give a way. If you look at this picture, you will understand better. See, here comes the transverse abdominis. It's the deepest muscle layer. So this is your obliques, mid layer, then your rectus abdominis, your linea alba. See, the picture in the left side is the normal one. That is pre-pregnant state. Okay, so this is during or after pregnancy. See how the muscle has given way for the growing uterus, because at term the uterus will come till here. Okay, so the muscle has to give a way for the growing uterus. That's why this diastasis rectus happens. So what are the common struggles for the mom? So the often mother complains of a flabby abdomen and pelvic floor dysfunction soon after a delivery. Then peripheral swelling, baby blues, that is nothing but the postnatal depression. So that is a quite serious issues. So that needs to be addressed now and then. Then mastitis, breast encouragement, inverted nipple, so the breastfeeding issues. Then upper and low back pain due to the posture, then pain in the epidural side. Then if they have undergone cesarean section, some women will complain of pain in the epidural side for a quite long time. Then the varicose vein, DVT soon after delivery. Then loss of libido, because they'll enter into the new parenthood, motherhood. So she'll be taking more responsibilities, and if she has undergone any normal vaginal delivery, definitely she will have that fear. So she'll have that fear. So then dyspareunia, then such a pain over the cesarean section and episiotomy and healing. So coming to the assessment. So by looking into the picture, you can say. So we don't do, in the acute stage, we don't do any detailed assessments. Actually, till 6 weeks, the detailed assessments for assessing abdominals and pelvic floor is not indicated. So simply you just check the auscultate the area for any secretions, check for the Hoffman signs. This you do for all the post-surgical patients. Then coming to the scar. So the phalansteal incision, can you make out the second picture? The phalansteal incision, then episiotomy, episiotomy scar, then you do the breast palpation for you have, then coming to the uh, incontinence or prolapse, you don't examine till, until the 6 weeks 2 months period is completed. Then you go for test assisted diagram. So these are the few basic things, basic examination assessment we do. So before you switch on to these assessment, so if you are just seeing the just delivered mother, so what are the things we look for? So you can remember it as bubblers. Bubblers is first you look for the B stands for breast. So for breast engorgement, mastitis, all that. Any then coming to the uterus. So you just check out for any uterus atony. If the atonic uterus is present, the women will have a atonic bladder also. So some studies states that these two are interconnected. So you can check for the urine retention, that is urine output. Okay, you can check for that. Then because if the patient has a atonic uterus, then the patient will have a continuous heavy bleeding. Then bladder and bowel, you need to check. Then lochia, you have to check out whether the patient has a continuous and steady heavy bleeding. If the patient has to change the pad for every hour, suppose if it goes like this for 3 to 4 hours, then that needs to be immediately reported. Then we check for episiotomy scar, try to check out whether we have any inflammations or infections, perineal edema, all that. Then emotional response. So some women, they don't respond, they will not adapt to the new motherhood. Suppose not only the new mothers, suppose if the woman is delivering for the second time, if they expect a boy child, because that is more common in India, still it persists, boy child, and if she gets a girl child also again in the second time, then she will be depressed, she will be like cornered by the family members. So all the stuffs would occur. So you have to check out for the emotional response. So already, even though the amidst of good environment, the mother is more prone for postnatal depression. So if the family members gives these kind of issues, or if the woman has any other issues, this will stimulate the things more. So you need to carefully check out for this emotional response, postnatal depression. Then S stands for your hormone sign. So the hormone sign to check the DVT. So before you, we all know how to check the hormone sign. You just squeeze the thumb and do the dorsiflexion. The patient will have a pain, or you will find redness and swelling over the calf muscle, the erythema, the pallor sign over the calf muscles. So these are the bubblers. So if you find any one symptom in this out of these bubblers, please refer the patient immediately to the OB-GYN. Then if these things are all normal, then you can switch on to the our regular assessment. So you all know it's a SOAP format thing, have a subjective assessment and the objective assessment. So in the subjective is the thing you will ask the patient and you record. So that comes under subjective assessment. You ask the certain things from the patient, then you collect the information from the cases. That comes under subjective. Then objective assessment is you personally examine the patient and what you observe. That is objective. So in the subjective assessment, you ask about the general database. Then you have to ask about the chief compliance, then present history, the onset of problem. That is, you will just brief about the chief compliance. So from where all these started. Then coming to the medical history. So how you will ask the medical history. So you have to ask the patient like whether she's taking any medications or not. If she is taking any medications, then we have to ask how long she has been taking the medications, all that. If she had taken the medications for something else, then that also needs to be documented. Then coming to the surgical history, any previous surgical history, suppose for appendicitis or any previous cesarean section, all that. Then you have to write about how long before all these was carried out. Then coming to the obstetric history, we'll ask about GPLAS. That is a this nomenclature like gestation, variety, live birth, abortion, and stillbirth. So gestation is how many times the woman is pregnant. Variety is how many times she successfully delivered the baby. Live birth is out of the delivered babies, how many is alive. Then how many abortion was carried out. Then the stillbirth. Then you have to elaborate these things. So the gestation in the sense, you need to ask whether spontaneous or whether she has taken any treatment. Then periety, you have to ask about whether it is a cesarean or a normal delivery. So if it is a normal labor, then you have to ask detail about the labor. So like how long she was in the labor, whether the episiotomy was done or not, whether she had any complication in each delivery, all that. Then so all this information needs to be carried out. So this information helps to advise how much the pelvic floor has endured. Then coming to the gynecological history, so we ask about any other gynecological conditions. First we ask about the menstrual cycle, whether it is a regular or irregular. Then we'll ask about whether the patient has any form of treatment like for PCODs, for fibroids, all that. So all needs to be documented. Then in the personal history, you will ask about the dietary habits, smoking, alcohol, and all that. Then socioeconomic history will ask, so whether she is the breadwinner of the family, how much she earns, all that. Then the fetal history. Actually, I feel this is a record for proper referral. So about the fetus, what you write is like about the gender of the fetus, height, weight, head circumference, Apgar score, then feeding, whether number of times, actually it is indicated to feed the baby every 2 hours. Even whenever the baby gives a cues, then also you have to feed. Then you have to check about the how many diapers. Okay, then you can check for the basic primitive reflexes, and you can check for any congenital deformity. If you find any deformities or any like like anything like cerebral palsy, all that, then you can refer, do a proper reference. For that purpose only, we just evaluate the fetus. So this will be done already by the pediatrician. So still we just make sure to give a holistic approach. So that's why we do the examination of the fetus also. Then coming to the objective assessment. So on observation, check out for the posture. Then abdomen. So abdomen, the type of incision, then any skin discoloration, any scars over the abdomen, any evidence for hernia, umbilical or any inguinal hernia, umbilical deviation, which means muscle weakness. Then you'll just observe the perineum. You check out for any prolapse, hemorrhoids, vaginal discharge, scars. Okay. Then on palpation, um, you check for tenderness or bulging or any protrusion over all these areas, this abdomen and perineum. On examination, so this will be modified based on the patient condition. Suppose the patient is in an acute stage of postnatal, you don't do a diastasis rectus examination or incontinence examination. Okay, you don't check for any muscle power on that. So you just check for the vitals. Then incontinence, you have a cough stress test. Okay, so you can just observe. You can put the patient in prone line. You can ask the patient to cough, and if the urine leaks, a stream of urine leaks, or any reproductive organ comes out while coughing, then you can just make out, okay, there is evidence for incontinence and prolapse. You cannot check in detail. Okay, so it needs at least 6 weeks postnatal. So if the woman comes to you at the second month of her postnatal period, then you can very well do the examination. Then as usual, the pain scale. If the woman complains of any pain, then you can do a pain scale. Then you can check for swelling, like pitting or non-pitting edema over the periphery. So that. Then you will list down the problem. Then you will write your aims and goals. So the postnatal goals. So can you see my first picture? So that is slow and steady wins the race. So that is the mantra for postnatal rehabilitation. Okay, so you cannot you need utmost patience, both the therapist and the patient. That's why we have to educate the patient. So in the overnight, the flabby abdomen does not go away. So they have to wait on. Okay, so because after delivery, some women will encounter various problems, so which will prohibit them from doing the exercise. So we have to properly explain them, educate them. Okay, so you can do a slow and steady exercises. Then first one is education, educating, then breastfeeding. So if the you have to do a proper assessment whether the baby is latching good or not, whether the woman has adequate milk supply, whether the woman has any breastfeeding issues like mastitis or breast engorgement, all that needs to be checked. And if the woman has one, then we have to treat them. Through this, we'll establish the breastfeeding. Then we'll help to overcome the baby blues, that is, overcome the depression. If you find the woman is depressed, you try to give counseling. If the woman is still, if you could not help the women, you can do a proper referral to a psychiatrist. Then good posture, because if the woman maintains a good posture, so almost the things will fall in place. Okay, so we have to educate them about the good posture, and we have to insist the mother to maintain this. Then you start with the stabilization exercises. Once the diastasis recti and pelvic floor dysfunction, all this has been fixed, then the women can slowly switch on to the other type of vigorous exercises. If not, the women will see a changes if she directly switch on to the high grade exercises. So, what are the telltale signs for the postnatal exercises? So, 3 signs. One is incontinence, other one is turning of the belly, and pelvic pressure or pain. So, if the women, you just look into the picture, if the women has a cooling of the abdomen. You look into the second picture, the woman is lifting a weight, and can you make out the cooling of the abdomen? So if the woman has a cooling of the abdomen while doing any type of exercises, you have that is a telltale signs, which means the condition will get more water. Okay, so this should not happen. And while doing exercises, the dribbling of urine should not occur. So which means you are putting extra pressure on the already weak muscle. Okay, so it's not going to work out. Then any pelvic pressure or perineal pain. Okay, so these things, if you encounter these things while rehabilitating the women, either she is doing the exercise in a wrong way, that is one kind. Then still, if you make sure the woman is doing in the right way, still the woman has these symptoms, then you can ask the mother to go with the low grade exercises. Okay, you can change the exercises based on the women type. So it's not a good idea to recommend the exercises which demands an increase in intra-abdominal pressure. Those exercises or any spinal flexion exercises, then crunches, any type of crunches, abdominal crunches, reverse crunches, all that. Then abdominal stretching. Already the muscle is weak, so there is no point in stretching the muscle. So some women will do the cobra pose, all that. So those things. Then bilateral SLR, push-ups, front plants, any twisting movements, and weightlifting exercises. So these things needs. So we have to refrain from prescribing these kind of exercises, and we have to educate the mother not to do these exercises, because nowadays we have access to like internet. Everyone has that, so they'll just browse in the internet and they just think like if they do a strenuous exercise they will just fix the flabby belly soon. So actually that is not the fact. So that needs to be clearly explained to the mother. So these all must be included in the postnatal education. Then coming to the physiotherapy management. So in the acute postnatal period, you will start with the diaphragmatic breathing exercises. So how do you do the exercises? Look into the picture here, the second picture from the left side. Yes. So you just take a deep breath, okay? Then take a deep breath, then you just hold it, 1, 2, 3, then you tuck your lower abdomen. Okay, do a posterior pelvic tilt. You pull your pelvic floor up and you slowly exhale. The inhalation and exhalation ratio must be 1:2, which means you inspire for 1 minute and expire for 2 minutes. Okay, so those breathing exercises can be done, because if you do a posterior pelvic tilt, this engages your TA and the pelvic floor muscles also. Okay, so it is advisable to do the posterior pelvic tilt. Then ankle toe movement. So this we normally give for any post-surgical cases. Then posterior pelvic tilting exercises. So how do you teach the posterior pelvic tilting exercises? You just put your hand under the lumbar lordosis, okay, in lumbar area. Then ask the patient to put the women in crook lying and ask the mother to press your hand with the back. Okay, so if the mother is not able to do that, then with your hand you can just give the cues. Okay, you can tap the back or scratch the back, so that by doing this you'll give a cues to the mother, so that she can do a posterior pelvic tilting exercises. Then you mobilize the mother as soon as possible. Some mother will be very reluctant. Some will just move around at the day 0 of delivery. On the day of delivery itself, they just move around. So it depends on the mother endurance. So you have to psychologically boost up the mother, and you try to fix. If the mother has any pain, then you can encourage the mother to move around as soon as possible to prevent the further complications. Then the pelvic floor exercises. Some study claims that if it's a normal labor, they can start doing from the labor table itself. Some study claims that like if the pelvic floor exercises is done during the menstrual cycle. So mother will end up having the endometriosis. So there are controversies. So what I personally advise is, so wait for the blood flow to stop, because after delivery the women will have a heavy blood flow at least for 3 to 4 days. So once it is stopped, then you can start the pelvic floor exercises. So till then you can indirectly activate the pelvic floor by doing the TA contractions, posterior pelvic tilt, all that. Then corset prescription. Corset prescription is, see, look into the picture, the last picture from the left side, you have a corset. So how you have to put the corset is from back to front. So the reason being is, see, you have your abdominal muscles here. As I told you, you have a abdominal muscles on both sides, which is connected through the linea alba. So now after delivery, you will have a diastasis recti. The separation of the muscle will remain the same. So by putting the corset, what you're doing is you're just approximating the muscle. So after a labor, your body will try to heal naturally. Whatever the damage is done, it tries to restore. So in that time, you just approximate the muscle so that the collagen tissues, it will help for the collagen tissues to get formed between the two sets of abdominal muscles. So for that purpose, you have to do a corset prescription. If the women is not affordable for the corseting, so you can ask them to go with the thick cotton cloth, like a cotton sarees or cotton dupattas. But the thing is, they should not give the they should not do it very tight. At the same time, they have to cover the whole trunk from top to bottom till ASIS. The nicely your muscle has to be wrapped from back to front, not from front to back. So from back to front, nicely you have to wrap your abdominal muscles around. Then coming to the perineal hygiene. So the perineal hygiene, if the woman has any perineal tear or done the episiotomy, definitely the women will have a pain over the perineum. The women will have a allogia for a week or a couple of weeks. So it's imperative to maintain the perineal hygiene. So ask the mother to wash and keep the perineal area clean and dry. So it's advisable to use the hair blower or something after every use of wash. Then coming to the defecation techniques, look into the picture. So this is how you sit on the closet. So suppose if while sitting like this, look into this picture. So this is the picture of the anorectal angle while sitting and squatting. So if you squat nicely, the anorectal angle will be open. So it will be easy to evacuate the bowel content. So for that purpose, you ask the mother to put the footstool under the foot, and the knee must be little bit above the hip, and she has to sit in this way with a neutral spine. She should not bend down, or she should not use any maneuver like she push the perineum with the hands to evacuate the bowel content. All that should not be done. So whatever she is, and she can evacuate and come. So if the woman has episiotomy wound, then you can ask the women to hold the tissue. Okay, so she can fold the tissue and she can splint the wound while evacuating. Then for cesarean section also, if the woman feels pain over the abdomen while evacuating or something, she can splint her wound by using the sheet or a towel. Okay, so splinting means like I have seen the the students, like they teach the patient they just put the towel roll on the wound and they just compress. Okay, so it is not like that. Splinting is you just support, you just keep the towel under the thing and you just support, you splint the wound. Okay, it's not like putting the towel roll on the wound and you compress it. Okay, so that techniques has to be clearly talk to the patient. Then various feeding positions. Okay, suppose if it's a twins or if it's a single baby, then how to do feeding, like cradle hold, football hold. So like that, various feeding positions you have to teach to the mother. Then the relaxation techniques, the Jacobson techniques, the progressive relaxation techniques you can teach to the mother to overcome the postnatal depression, or make the mother to think of the good moments happen during the antenatal period or happen ever in the life, all that. Then educate and make the mother and family about the postnatal depression. This is very important because actually they play the major role, because the family members like the mother, husband, the family members need to be more supportive for the mother. So we have to educate the family members too. So these all we do in the antenatal class itself, in the last class when we talk about the postnatal thing. So if not, the mother did not attend the antenatal class, you can talk about all these things in the postnatal. Then I'll explain things in detail. So first one is stress. If the mother is in stress, okay, if you don't identify she is in a stress, postnatal depression, whatever the exercise you give, how much ever you try to have it, things will not fall into place. So first you need to fix this. Okay, so postnatal depression. So include the birthing partner in all the virtual classes or the classes you take in person. So they have to do the adequate planning and preparation. So they have to divide the day for rest, walk, exercise, and hobbies. So like that, they have to divide their day. So if only the mother plan for this, this will not work out. So that's why you have to educate the family members or the husband or the mother who are taking care of the mother, because someone has to need to take care of the baby. So you have to talk about the postnatal depressions, or that you have to educate them adequately. Then you will give the relaxation techniques, deep breathing exercises, like yoga, all those stuff. Then imaginary techniques, all that. Then encourage the aerobic activity. The study shows that the aerobic activity helps to um, improve the postnatal mother's psychology. Psychology. So it helps the mother to have a good mood, and they feel positive throughout the day. Okay, so some others, by looking into their own body itself, will make them depressed. Okay. So if you put them in a low grade aerobic activity, simply walking, listening to music and walking for half an hour will be beneficial. Then check out for signs of stress using inventories quite often. So always use any inventories, that is scales, questionnaires. So you to check whether the mother is in stress or not. Then encourage communication with friends or relatives or phone. Ask them to stay away from negativity. Why I have mentioned communication over phone is now we are into a uh, pandemic situation. So it's not possible for the mother to go out and roam with the friends and go out and meet the relatives. So in that case, they can have a communication with their friends and relatives over phone. And better if the mother stays away from the media. So if they keep on hearing about the increase in COVID-19 cases, all that, this will put the mother into a depressed state, and she may be very anxious, like if what if she gets into this COVID-19, or what if the baby gets in. So all will make the mother depressed. So it's okay to stay away from then coming to breastfeeding. So it's quite natural thing. Okay, so all the mammals has this breastfeeding. So what are the benefits of all the nutrients what baby needs, even the immunity also. So then the first 2 days the mother will get a colostrum. So that is the you call it as a liquid gold. Okay, colostrum. It has the antibodies requires for the baby. Then the woman from the day 3, the woman will have a good milk supply. So if the woman is a primary, then you have to give more support since she will be unaware of all the things. So you have to give more support to them. So you have to educate them that you have to feed the baby. Feeding the baby will make the mother to shed the weight. Then breastfeeding provides a emotional and psychological contact with the child and mother. So it increases the mental development of the child. Okay, so it creates a good bond between the child and the mother. So all that. So you have to properly educate them. Then you have to teach them to identify the hunger cues of the baby. Just look into the picture. See if the baby is hungry, stir its head, open the mouth, turning head for rooting. Just rooting is the reflex present. It's a primitive reflex, right? So try just turn the head, then it stretches, increases the physical movement. They just finally they'll put hand to mouth. So still, if the mother did not realize the baby is in hunger, the baby will start cry and it will be agitated. Then breastfeeding issues. The common issues will be the breast engorgement, mastitis, and inverted. So the breast engorgement and mastitis. So I have given a study reference here. So in this study, they have used the non-thermal ultrasound and they have used the hot compress and cold compress also for treating the breast engorgement and mastitis. So in the breast engorgement is a block text. So before you treat the breastfeeding issue, you just first check out for the root cause of the issue. Okay, so you have to fix the root cause of the issue. Then only uh, it will not reoccur. So you try to fix the root cause. So first check out for any incorrect latching and positioning of the baby. See, look at the picture. This is the correct latching. So some other they just give only the nipple to the baby. So that is not the right way. The whole areola has to be inside the baby mouth. See, the lips has to be, lower lip has to be fair out. Then the mouth has to cover the whole areola. Okay, so this is the correct way of latching. So you have to assess for latching, and even though if the baby is able to latch properly, sometimes the mother will not be able to hold the baby properly for good latching. So that holding also needs to be assessed. Whether the mother use any supplements or pacifiers, okay? Because if the mother gives any supplements like bottle feeding, something like that, okay? So the baby will not try to have a milk directly from the mother. So this also leads to breast engorgement. Whether if the mother is using pacifier, giving pacifier to the baby also leads to this condition. Then any abrupt weaning. Okay, so one fine day suddenly if she tries to wean the baby off, then that also leads to breast engorgement. So in this case, you just compress the breast when the baby try to suck. When the baby sucking become less effective. So that also, some other does this. So that also needs to be assessed. So you can apply cold to soften the breast for a few minutes after the breastfeeding. Then ask the mother to hand express the milk, teach the proper lactation techniques, give hot compress, non-thermal ultrasound can be given. Then wear a well-fitting supportive brazier which is not too tight, then these things you will evaluate and you will advise the mother. Then for inverted nipple, you can use shields. Okay, some shields you can use. Then Hoffman techniques. Hoffman technique is nothing but using the thumb. You just give a lateral pressure, upward and downward pressure around the areola to bring the nipple out. Okay. So that is the Hoffman's technique. So this you can teach the mother. She can do it on her own. So breastfeeding and COVID-19. So suppose if the all the mother will have a doubt, is it safe to breastfeed if the mother is already infected with COVID-19? So the WHO says it's safe to breastfeed. Okay, so they did not find any antigen over the amniotic fluid or over the cord blood or over the breast milk also. In fact, if the mother has a COVID-19, already the mother's body will have started producing antibodies for the same. So it would be beneficial. And these are the precautions you can take. The mother can wear the mask. So you can wear the shield for the baby. If the mother doesn't want to isolate the baby, if she wants to keep the baby with her, actually skin to skin contact is necessary to establish a breastfeeding. So if the mother wants to keep the baby with her, then she can wear a mask and she can use the shield for the baby. Then the other way is she can pump the breast milk and ask someone who is not infected to feed the baby. Then the basic precautions can take like wash your hands before touching the baby, wear a face mask, and clean the feeding bottle pots appropriately and the breast pump also appropriately if you are using it. Then coming to the wound care. Wound care means if the woman has a cesarean section or the woman has a episiotomy also, so the IRR is proved to be very beneficial. So we can give IRR, then ultrasound. Ultrasound you can use non-contact method. You can use the water packet or something. You can put the gel on that and you can give ultrasound. So non-contact method you can use. That cooling gel pads for especially for episiotomy. It's available like it will be like a normal sanitary napkins. So the women can keep it for a while. Then sitz bath. Sitz bath it seems to be more effective. So sitz bath is like you just fill the tub with the lukewarm water, make the mother to sit in the tub and ask the mother to do a kegels, fast kegels. Okay, so this fast kegels, it gives a local pumping effect and it helps to remove the pain producing substances from the particular place that is around the perineum, and it helps perineal tissue to get a good oxygenated blood, which in turn helps in healing the wound. So whenever the patient use the washroom, ask them to pat the perineal area dry. They can use a blower or something. Okay, so by using sitz bath, using blower, and maintaining the basic perineal hygiene itself enough for the episiotomy wound to heal. So in some cases, if and splinting the wound during defecation. In some cases, if all these things is not worked out, then you can switch on to IRR and ultrasound. Then the posture correction exercises. Look at here. So posture correction exercises, you can do shoulder shrugs, then you can give a pectoral stretch, deep neck muscle stretch, trapezius stretch, wall slide exercises, okay, chin techniques. Then you can prescribe the braces if necessary. So usually the women is more prone for the kyphotic posture because there will be increase in the breast size. Since she's feeding the baby, there will be increase in the breast size. That is one cause. The other one is, she'll be holding the baby for a long time. Okay, so she holds like this. She struck the shoulder, she'll just protract the shoulder and hold the baby. So if she keeps tends to keep this pose, that is shoulder, keeps the shoulder in, like protracted. So you can educate the mother. That is one thing, so that she can consciously keep her posture right. But being a mother, that is very difficult. That will be very difficult actually. Okay. So what you can do is, you can teach this postural correction exercises. So ask her to do it at least once in a day. So initially you don't just overburden the mother. So I have given all these exercises, but it's not that you teach all the exercises. Okay, so you teach one at a time and you make the mother to do that slowly, slowly, slowly. You increase the thing because already the mother will be sleep deprived. She will be overloaded with the work. Uh, so if you again load her with more exercises, at one point she will just quit the exercises. Okay, so that should not happen. So you slowly, slowly you teach her exercises. So never overburden the mother with the exercises. Then coming to the intimacy. So most of the women in our culture, so they don't vocalize this. If they have any issues also, they don't vocalize this. That is one. So it is our duty to extract the history. So it's not advisable till 6 weeks. It's not advisable to have a sexual intercourse till 6 weeks. Then the woman will be fatigued and she'll be in the new motherhood and she'll be loaded with the responsibilities. So this all leads to loss of libido. If the woman has undergone episiotomy, she may have a pain. Okay, pain during the sexual intercourse. That's a dyspareunia. So in this case, there are treatments available. So you can use a vaginal dilator to treat the dyspareunia. First, you have to find out the root cause. Okay, so dyspareunia is again a big topic. Okay, so you have variety of treatments. So, but you have to find out the root cause. Then you have to treat accordingly. So usually we give vaginal dilators. Then counseling. Okay, have lose the interest in the sexual activity. So in that case, you have to, if you find one, you have to give a proper reference to the psychiatrist. So they do the examination, they just talk about these things, and they are the right person to fix the issues. Okay, so the proper referral needs to be there. So in the breastfeeding also, so if you still find the issues, so it's better to refer the mother to the lactation consultant. Then pelvic floor dysfunction. So pelvic floor dysfunction is during third trimester itself. The woman will have a stress incontinence because the bladder will be compressed, and moreover when the bladder is just above the lower part of the uterus, right? So when the uterus grows up, it pulls the bladder also up. Okay, the bladder capacity may increase, but the bladder volume does not increase. Okay, so in that case, whenever the bladder is little fill, also the woman feel like passing away. Okay, that would happen. So this pelvic floor dysfunction comes from antenatal period to the postnatal period. So it's not the new thing happening. Sometimes it may it's not necessary that every woman must have pelvic floor dysfunction during antenatal period. So sometimes due to any obstetric injury, the women may tend to have a pelvic floor dysfunction. Pelvic floor dysfunction is a broad term. It comprises urinary incontinence, fecal incontinence, pelvic organ prolapse, pelvic organs such as uterus, bladder, so all that. Then sexual dysfunction. So this pelvic floor dysfunction is a broad term, encompasses all these four symptoms. So generally we prescribe Kegel exercises. So pelvic floor exercises. So Kegel exercises, you have fast and slow Kegels because your pelvic floor is made up of 60% of slow twitch fibers, 40% of fast twitch fibers. So you have to activate both. The slow twitch fibers will be helpful in holding the organ in its place, and the fast twitch fibers will be helpful in sudden contraction. Like suppose if the stress is placed on the bladder, the fast twitch fibers acts to close the bladder neck. Okay. So this is slow. This is a slow twitch and fast twitch fibers. So this Kegel exercise has to be given for both slow twitch and fast twitch. So usually we do a assessment, then we prescribe. But here till 6 weeks, it's not recommended to do any pelvic per vaginum examination. So in that case, you can just by asking the patient how long she can hold verbally, then you can prescribe. So always prescribe the exercises. So this many sets, this many counts she has to do. So fast slow Kegels is, suppose if you are sitting, then ask the mother to sit on the chair with the neutral spine and the legs wide open, feet both the feet flat on the floor. Then she has to just close the passage like vaginal and anal passage. Then she has to close it tightly and she has to lift it up from the chair seat. Okay, so this is how you have to give proper instructions. So it will be hard for some women to understand the instructions and will not be able to make out whether the woman is isolating the pelvic floor and contracting, or she's just contracting the gluteals and adductor muscles. So it will be quite difficult, but by giving proper instruction with utmost patience, we can make them to learn the pelvic floor exercises. So slow Kegels is you just lift up and you hold it for a while, like 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So like this you hold, then slowly put the pelvic floor back on the chair seat, then relax. It's not like when the pelvic floor is on top on the 6th floor, then you just relax and put it down. You just throw the pelvic floor onto the chair seat. It's not like that. So clear instruction needs to be given. Just make the patient to sit with the legs open, okay, so that the vagina will be on the chair seat, not the butt. Then ask the patient to close the passage tightly, then slowly lift it up from the chair seat. Then hold it for a while, then bring it back to the chair seat, then relax. So this is how you have to give the instructions. So this is slow contraction. Fast contraction is after doing slow contraction for suppose 6 or 7 times. This is based on the patient's muscle, so it varies with the patient. Suppose if it is a 6 or 7 times the woman has done a slow contraction, then you have to ask her to do a fast contraction. Fast contraction is you just close the passage, lift it up, and you don't hold it for a while. You just immediately lift it up, then bring it back down and relax. So like that you do continuously for 10 times. So this is how you do the fast and slow Kegels. And you have vaginal cones, Benmore balls, like devices are available to treat the pelvic floor dysfunction. So this is proven to be more quite effective. This is kind of resistance exercise. Okay, so this is a vaginal cone. So you have a various weights. So you start with the least weight and you choose the cones. You have 2 cones. You choose the cone based on the vaginal size. Then you slowly start with the least weight and slowly you switch on to the higher weights. So this is like resistance exercises. How we do, how we use the dumbbells and theraband. So like that, this is also resistance exercises. So never stress the pelvic floor. See, look at the first picture. This is the normal pelvic floor. This is the weakened pelvic floor. How the pelvic floor actually it just pops or it comes down from its position. Okay, so never overburden the weak muscle. So in postnatal cases, the goal is slow and steady wins the race. So that is the goal. So that is the mantra actually. So you have to slowly increase the exercise repetition, exercise sets. Okay, you just don't rush the patient. If the patient wants, like if you feel the patient is rushing you, then you give the adequate education regarding this to the patient. Then coming to the diastasis recti. So we all know the diastasis recti is a gap. It's roughly between 2.7 centimeter or greater between the 2 sides of rectus abdominis muscle. This is called as abdominal separation also. See here. Look at the second picture, the separation of the rectus muscle. So how do you assess this? Okay, so you can do a self-assessment also, and it can be assessed by therapist also. Okay, so step 1, lie down on your back with both knees bent. Simply crook lying. Put the patient in crook lying. Cover the area which is not necessary to get exposed, like over thighs and the upper chest, like that. Then place your index and middle fingers at 3 levels. So the first one at the level of umbilicus, second 2 inches above the umbilicus, third one 2 inches below the umbilicus. Okay, so your fingers should be aligned side by side. Horizontally you have to check. Look at the third picture. You have to check horizontally. Okay, step 3. So you put the fingers, then ask the patient to extend the arm towards the knee. It's like doing the crunches. Take a deep breath, tuck in chin, which means he's intentionally, the patient is holding the breath. Then raise your head and shoulders off the floor. And as you raise your head off the floor, you try to blow out while coming up. And feel for any gap or dip under the fingers. So it will be like this. So you will feel a dip like this. Then lower your upper body back to the starting position. Then how do you grade this? You have mild, moderate, and severe. 2 to 4 centimeters, that is 1 to 2 fingers, that's a mild. Then moderate is 4 to 6 centimeters and severe is above 6 centimeters. So it's not like only the postnatal mothers get it, even the infant also get this, and men also get this. If it's a obese men, and they also get it. Even the nulliparous woman, if she is obese, she is also more prone for diastasis recti. Then, so for diastasis recti, the Tupler techniques. Actually, she's the one. She done a research on this, and she has proved some 6 moves, and she says that she claims that it heals the diastasis recti. First one is elevators. Elevators is sit with your legs crisscrossed, either in an armless chair or against a wall for a back support, which means your spine must be neutral. Breathe deeply into the bottom of your belly. Then exhale as you tighten your abs. That is, as you tuck in, bring your belly button back towards your spine and stop at the fifth floor. Actually, she has defined this tummy tucking in 6 floors. Okay, so these floors are nothing but imaginary thing. Okay, so you can try now. You just sit straight and you just do a tummy tuck in. You just do it slightly and it's in the first floor. Bring it furthermore, it's in the second floor. Furthermore, third floor. Furthermore, fourth floor. Furthermore, fifth floor. So as you suck your tummy in, so this floors also goes. Okay, get along. So first you have to hold it. That is like moderate intensity. Okay, to the fifth floor position. Stop at the fifth floor. Okay, you have to do it along with the breathing. So first you breathe deeply into the bottom of your belly. Okay, the breath you are taking has to reach the bottom of the belly. Then you have to exhale. As you exhale, you just tuck in your tummy to the fifth floor position. That is moderately you tuck in your tummy. Hold this contraction for 30 seconds. Then draw your belly to the sixth floor. Then slowly count to 5. Then return to the starting position. That is the fifth floor. Okay, so like that you practice this breathing first. Okay, then so because this even there are other studies, it proved that when you contract your abdomen and pelvic floor while you exhale will be more beneficial than one doing without uh, breathing. Then move to contractions. Begin in elevator position with one hand resting on your chest, the other just below your belly button. Breathe in with your belly in the first floor position, which means here you just start to breathe in with a just mild tucking, and then you exhale until you are at the third floor. So the third floor is the starting position for this exercise. Then tighten your ab to the fifth floor position and squeeze it well. Then return to the third floor. Don't just relax the whole tummy. Okay, so you just fix your third floor, then third floor to fifth floor, then fifth to third floor. Okay, so the tuck-in is between fifth to third floor, and you have to repeat it. So before you teach the Tapla technique to the patient, you know, first we have to implement on ourselves. Then we have to teach them literally, like teaching to the student, like how we teach to the students. So we have to teach them literally. Then you have to teach them literally to the patient to make them understand. Then you start with the moves. Okay, first make the patient to understand what is first floor, second floor, third floor, fourth floor till sixth floor. Make the patient to find out that. Then you teach them the move 1 is from fifth floor to sixth floor. Move 2 is from third floor to fifth floor, like that. Then move 3 is standing pelvic tilts. So standing with your back flat and knees partially bent, place your hands on your thighs to support your upper body weight. Tighten your abs into the fifth floor position. That is, which means you will be like doing it against, a little against the gravity. Okay, so fifth floor position. So while doing this, your tailbone will be tucked under. Okay, then count to 5, then come to the starting position, that is with the flat back. Then head lifts, lie on your back on a firm surface. So this is mandatory, because if you make the patient to lie on the bed, which is quite unstable, you know, the TA and multifillers will be already in the load. Okay, so you make sure to do it in a firm surface. Bend your knees, place your feet on the floor, simply a crook line. Then breathe into your belly. Then exhale and tighten your abs to the fifth floor. So your low back should flatten into the ground. So as you hold the TA contraction in the fifth floor position, you have to do the posterior pelvic tilt. That's it. So keep your abs tight, tuck your chin and lift your head off the ground and lower down slowly. Repeat for 10 times. So while doing this, what you can fix your eyes on the ceiling. Okay, don't bend your head much, because you would have heard about those exercises which activates the rectus abdominis. You just don't tuck your chin and simply just lift the head with your eyes fixed on the ceiling. So that is also one. But here you have to just tuck your chin and lift your head off the ground. This we all would have learned in the Margaret Holden book. Then leg slides. Lie on your back with your knees bent, again in the crook lying. Place one hand under your lower back and other on top of your belly. Tighten your abs in a foot floor position. Lift both feet off the floor until your knees are directly over your hips. Okay, so it will be in a 90-90 degree. Your hips and knees will be in a 90-90 degree. Then place one foot back on the floor and slowly slide your heel along the ground. Nothing but the heel slides. Starting position will be hip and knee will be in the 90-90 degrees. Then you have to repeat it. Then low back stretch. This is nothing but the knees fall out. So lie on your back with knees bent, arm resting at your sides. Tighten your abs and slowly drop your knees to one side. So you put the women in a crook line and slowly ask the women to drop the knee to one side. Then turn your head to the opposite side. Hold for 15 breaths. Now, hold for 15 breaths means it doesn't mean that you hold the breath. You take 15 inspiration and exhalation. Okay. So repeat on the opposite sides. Knees fall out. Okay. So this is proven to be more effective, and she has designed the corset also, and that corset also seems to be more effective, and you can prescribe the corset and make the patient to do these exercises. So along with this, you can ask them to do some basic stabilization exercises. Okay, so once the diastasis recti and pelvic floor dysfunction is fixed, then move on to the graded exercises. Otherwise, the things will get more worsen. Okay, so you have to educate this to the mother when you give a home advice. Ask her not to follow any layman advice. Okay, so she has to do the graded abdominal exercises. She has to start from the scratch, basic stabilization exercises, then she has to do. So this also, it's not necessary that she has to do all the 6 at a time. Okay, so she can slowly progress also. Then home advice, encourage activities to promote psychological health of the mother. So this is very imperative. So first you have to fix the psychological part. Okay, then continue the abdominal binder till your diastasis recti is sorted out. Avoid lifting straight up from horizontal line. Okay, when you just lift up from the supine line, your intra-abdominal pressure rises, so it will separate the rectus muscle. So what you do is you turn to the side and you get up. Avoid sudden twisting and turning from the waist. So there are certain exercises, like with the medicine ball, we just twist and turn. So, and with the we'll have stick exercises, a stick on the shoulder, and we do the oblique crunches on that. So these exercises are known to give a good body shape to a women. So already women will be with the flabby abdomen and all that. So by looking into these exercises, she will be inspired. She will, without doing a stabilization, fixing the rectus abdominis, straight away she will start with this. Just imagine with the open abdominal muscle, if she does the abdominal crunches, both the sides, the muscle will still separate. So you educate the mother about the and ask her to slowly give a then avoid sudden twist or turning from the waist. Then keep thinking core and pull belly button through to spine whenever you lift, twist, or get up from lying. This knack technique in the for the pelvic floor, and simply tummy taking, and she has to maintain the neutral spine. Suppose if she has to sneeze, cough, or if she's lifting a baby or any baby stuffs, she can uh, uh, voluntarily contract the pelvic floor, that is muscle around the vagina and anus, and she can do that. So by doing this, she is giving a passive support. Like that, she can do a tummy tucking, but make sure she doesn't hold the breath while doing any of these exercises. Then maintain a good posture. Then it is not advisable for a woman to begin another pregnancy before full recovery of the rectus muscle. So with this, I finish my presentation. I hope this will be helpful.
Thank you, Dr. Deepthi, for a beautiful presentation and wonderfully presented, included everything that concerns a postnatal female, from psychological aspects to physical aspects. I think there is no discussion as such left in the presentation, because each topic was covered as if it could be a lecture in itself. So I feel that there is no question as such. Just wanted to ask you about some ladies preferring underwater deliveries or
Yes.
in water deliveries. So how is that better than anything like a normal delivery or a hospital delivery?
Sir, actually, it is practiced in Western sides, and but recently I have heard in India also, like they are doing it. Thing is, the water birth, the tub will be filled with the lukewarm water. So usually when the woman is in the labor pain, we'll advise them to take a warm shower, all that. So it gives a kind of distraction and soothing effect. That is one.
Okay.
And the problem with that is, I have seen some studies, it claims that the baby which is delivering under the water, right? So sometimes the water aspirate seems.
Okay.
So that is the only problem they have
So
encountered
that
with
is
the
why maybe
water
it
birth.
is not so popular
That needs
still.
more skill, it seems.
Right, right. Okay. Thank
Yes.
you, Dr. Deepthi, for a very informative session today. And
Thank
I
you,
think
doctor.
it is very appropriate for general population also to view this lecture. Thank you so much.
Thank you,
Thank you,
doctor.
Dr. Deepthi. Thank you.